Welcome everybody to this webinar. The global epidemic of hypertension is largely uncontrolled, and hypertension remains the leading cause of disease death worldwide. Not enough hypertensive patients are diagnosed, as only half are. When treated, again, a small proportion is really controlled, and one of the reasons is the lack of adherence, as it is estimated that more than half the patients treated are not adherent to their antihypertensive treatment. Therefore, it means that more than 200 million hypertensive patients treated every year will stop their antihypertensive treatment too early. Today, we are going to talk about this major issue as it has important and severe consequences for patients. Why patients are not adherent, what is the role of the doctors and companies, and how can we improve this situation? To respond to these questions and discuss some potential solutions, we are pleased to welcome Professor Pr Burnier, Honorary Professor of Nephrology and Hypertension at Lausanne University Hospital in Switzerland, Neil Johnson, Director of Strategy and Development, Global Heart Hub, the International Alliance of Heart Patient Organizations, and Professor Neil Poulter, Professor of Preventative Cardiovascular Medicine at the Imperial College in London. So, how can we explain non-adherence to treatments which contributes to the poor control of blood pressure in hypertension? To start with, how shall we define adherence? Professor Burnier, would you like please to start explaining us?
Yeah, hello, thank you for the introductions. Yeah, the medication adherence is really a process. Give a prescriptions, and the patient has to go to the pharmacy and get it. And this is the initiation, which is already sometimes a problem, but we know, for example, that in the US, 20% of people do not get the initiation. Then they have to start to take it every day let's say, to implement the treatment on a day-to-day basis. And this is a second aspect. And then they have to stay on therapy. And this is one of the major issues in hypertension and almost all chronic disease. It's what we call the persistent. You can be relatively adherent on a day-to-day basis, but if you stop, as you mentioned in your introduction, after 6 months or after 1 year, then you lose all the benefits. So persistence is one of the big issues. And stay on therapy is one of the big issues in the management of hypertensive patients.
Professor Poulter, you are president of the International Society of Hypertension, so you have to face this challenge of adherence, I would say, on a daily basis. Would you consider that a more important problem in hypertension than other chronic diseases?
Well, welcome. Thank you. I'm the immediate past president of the International Society, but you're absolutely right. It is a problem we all have to face up to in clinical practice. Interestingly, this problem of lack of adherence, as an expert like Professor Burnier could tell us, isn't just peculiar to high blood pressure. You see it in infections. People stop their antibiotics. You see it in lipid lowering. You see it even in conditions where patients have got pain and their treatment is to treat the pain. They still don't take their tablets. So it isn't peculiar to blood pressure, but why it's so important in high blood pressure is the size of the problem. And if you've got about 1.5 billion people around the world with high blood pressure, you then start to realize, really highlighted by what's on this slide, is that it is a cause of a huge amount of problem. Raised blood pressure is the biggest contributor to the global burden of disease and to global mortality, leading to 9.4 million deaths. Now, I wrote that in 2015. And if you bring that up to speed with the next click, you'll see that takes us to 10.4 million deaths each year. So it's the size of the problem which makes this particularly poignant for high blood pressure. And it's particularly important because if you look on this slide, it shows the benefits of lowering blood pressure. And you can see for a relatively small amount of blood pressure lowering, you get big benefits in terms of cardiovascular events, coronary disease, strokes, heart failure, and all deaths. Huge reductions just by lowering the blood pressure if we do it. So it's very important we get round to that. Now, given that background, how well are we doing? If you look on the next slide, you'll see this slide shows stratified by countries around the world from high down to low income countries, the awareness rates, and then if you move to the right, the treatment rate, and then you move to the right, the proportion of patients who are controlled. These are hypertensives from around the world. And if you just look in the bottom row, the total, you see that under half, 46.5%, are aware of their problem, so we're not managing it. You then see not all of them get treated, 40.6% of all hypertensives, but then the control rate is 13.2%. So a tiny proportion are actually getting control of hypertensives out there. And so the question is, why do we not control blood pressure? We've shown if you treat them, people get big benefits. Why don't we do it? And one of the key answers to that question is lack of adherence. We don't take our tablets. And that's what we're here to talk about. So yes, a huge problem in hypertension.
Yeah, you gave this amazing figure of 9.4 million deaths each year. So we're going to talk about patients now with you, Neil Johnson. You know a lot about psychology since you hold a master's degree in psychology from the National University of Ireland, Galway. According to you, and from a patient perspective, how can we explain patients' reluctance to take their medication, even if recommended by their doctor?
Well, I don't think you need a qualification in psychology to understand that it's a very complex question. It's ultimately a question of human behavior. And by that I mean moving somebody from not taking a substance or a medicine to taking one requires a behavior change. And that behavior change has to be understood in the wider context, the socioeconomic context, the personal patient context, the context of the disease, the context of the health service. There are many variables that come into play, but ultimately I think it's about the patient's position in terms of their readiness to change and readiness to adopt a regime of medication with a view to improving their health. And in the context of hypertension, of course, one of the issues is that by taking medicine, you're not necessarily going to feel any better. So that makes it a little bit more difficult to make a convincing case for taking
Professor
medicine.
Poulter or Professor Burnier, would you like to react to what has just been said?
If I can make one comment, I totally agree with what has been said, but if you really realize for a physician to introduce a treatment to new hypertensive patients, all odds are against him. I mean, the patient doesn't feel anything. He eventually feel side effects if he starts on the treatment, and he don't see the benefits. Lowering blood pressure, very often people don't even measure it at home, so they don't really see. So it's really a tough, a tough situation for the physicians because, all odds are against him to succeed at the beginning, I would say.
Neil Poulter?
Well, I just agree with all that. I think the reasons people don't adhere to their therapy is mixed and varied. And I think that's why the research tends to suggest that one treatment doesn't help everybody, because there are lots of different reasons why people don't take their tablets. And unless you get a catch-all that deals with all those different reasons and can deal with it, you're not going to be able to get a good benefit right away across the spectrum of activity.
So it's very clear that adherence to treatment in hypertension is a real issue. Professor Burnier, what are the consequences in case of non-adherence to treatments, and what are the potential solutions?
Well, I mean, the benefits are relatively easy to think about. I mean, as we used to read in the paper, drugs are working only if they are taken. So if you don't take your drugs or your antihypertensive treatment, of course you will have a suboptimal blood pressure control or eventually no blood pressure control. So you will not get the clinical benefits. then in the healthcare system and physicians, they will be faced with more accelerated and severe hypertension, so people who really need to have it, but they don't feel any symptoms. And the consequence of this is what Neil Poulter said before. If you have elevated blood pressure, then you have more preventable cardiovascular complications, which in some respects seems to be stupid to not. You can prevent it and you don't do it. And we'll have more hospitalizations, more premature deaths in relatively younger hypertensive patients, and also potentially a greater healthcare cost. So I think that's what convinced me to work on this adherence issue, because it's a win-win-win situation. I mean, if you improve adherence, the patients win, the doctors win, the healthcare costs win. I mean, everybody has something to win into that. Now, how to deal with it? Of course, it's, as we heard before, it's a complex issue, and it seems like it is a kind of a situation where you have to individualize the approach, because as Neil Poulter said, everybody has his own reason not to do it. Of course, there are some big issues that people mention. I mean, they usually forget, not necessarily intentionally, or they refuse the treatment because they're not convinced that it's beneficial for them. But I think the bigger issue we are confronted is we are not good at diagnosing non-adherence in clinical practice. And if you go, probably everybody has been to his doctor, and the typical question is that, do you take your medications? You know, and if we ask this question, 90% people say yes. But if you really measure it objectively, you will find out, as you said, that people forget very often, and perhaps they take it, but they take it, 7 on 10, 8 on 10, half of them. So they're not totally wrong when they say they take it, but they don't take it correctly. So, and in the practice, we have no tool. For a long time, we had no tool to diagnose the non-adherence, except talking with the patients, we know it has some limits. Today, if you see on the slides where you have all the process of since the prescriptions and the return of the patients to the physicians, of course, there are several steps where we can have help and probably get some information. Of course, we can get some information from the pharmacist, for example. In some countries, there is a good collaboration between pharmacists and physicians, and the pharmacists know what has been bought and what perhaps has been brought back. At home, of course, we can have some helps from the family and from other local tools, electronic monitoring, for example. And there are now a lot of other methods, and I would say the most popular today is the monitoring of the drugs in the urine or in the blood. You have to think that the ideal method of measuring should have two criteria. It should prove that the drug has been taken, which is not so easy. It's only the drug levels which will really prove that. And ideally, it should also provide you with the history, because people can do good a day and bad the next day. So if you don't have the history of adherence, it's very difficult to assess what people are doing. For example, now, people are on holiday. They don't take their holiday. They don't take their drugs with them in the holiday, so they have 1 week free or off treatment. Then they come back, they take it again. When they come to you, you ask, did you take your pill? Yes, I took them. But they forget that they forgot during 1 week during the holidays. And with the electronic monitoring, for example, we have seen a lot of this kind of example. The most classical one is that people, for example, don't take their drug during the weekend. Weekend is off treatment for any reason. Saturday, Sunday, you have about almost half of the people don't take the drug on these days. It's incredible, and there is no rationale for that. So,
you said that many patients say they take their medications, whereas in reality they don't. You mentioned the methods of monitoring. Neil Poulter, what do you think about those methods which enable to detect non-adherence and then maybe to improve adherence?
Well, thanks. It is very difficult to assess. as Michelle said, in the past, we've asked the patients, and one of the worst things you do is, are you taking your tablets? You get assertive like that, it makes the patient defensive. You don't want to be saying that. I think there are ways of trying to find out in an empathic way. Most of these patients are elderly. That means they're on several drugs, maybe 20, 30 drugs, some of these people, and are huge numbers. And so one of the things I say is, you're on a huge number of tablets here. How do you manage to remember to do this? How do you do that? And then that enables the patient to say, well, you're right, I do forget occasionally. And then you can work on methods, having a dosset box where all the drugs are put out and laid out for them, etc. There are more technical methods, as Michelle mentioned again, where you collect the urine and that tells you whether the drug metabolites are in the urine. So that gives you, I suppose, the evidence that the patients are not taking their tablets. But I think the key thing is to try and understand why they are not taking the tablet. The first thing is to assess it. You can assess it and find out. Let's say you find out. The next question is, okay, why are you not doing it? And that might be because you can't afford the tablets, or because it affects your sex life, or because you don't really understand. You treat it like an infection. And you think, well, I took them for 2 weeks. What's wrong with that? Well, this is for life. And it's the educating the patients that needs to be inculcated. It needs to be worked with the patients so they get it. So first thing is assessing. Once you've assessed, and there are various methods, which, as Michelle points out, they're not great, but we've got some. Once you've got those, once you've assessed it, you've then got to find out why the individual is not taking them, and then work with them to try and turn that around.
The two of you addressed I was going to ask Neil, because the two of you addressed the question of digital health, and we see how it can improve how it can help to improve adherence. But Neil Johnson, I wanted to ask, what do patients think about those methods? Do they have the feeling of being kind of controlled, or are they aware that it's a real solution in order to improve patient outcomes?
But just really, in answering that question, just to respond there to the last comment about, making a point of discussing the adherence issue, notwithstanding the very complex patients on polypharmacy. If you take the more straightforward, typical patient that maybe has 1 or 2 ailments that require medication. When you think about, for example, in primary care, the typical visit, which is also a very short visit, the primary focus is how are you feeling, the diagnosis, and the very last thing that happens is there's a script written, probably written in a matter of 30 seconds and handed to the patient. Now stand back then from a patient point of view and evaluate how significant is that script prescription in that entire engagement. It was the last thing that happened. It's very low on the pecking order. And the next time I go back to my physician, it's extremely unlikely, if at all, that there'll be actually any reference to medication. So I think one of the things here is that perhaps, and I know time is a precious resource to doctors, perhaps if the doctor could maybe make more of an emphasis on a discussion on the medication, and to actually probe into some of those issues that Neil has outlined, the why, and look at perhaps ways in which that could be changed or assisted. One area, of course, is the whole area of patient education and patient activation around their own health. That, of course, requires potentially a set of skills that maybe doctors don't have acquired perhaps in their training, or don't have the time to practice. I'm speaking, of course, of things like motivational interviewing and so forth. But the other thing is, to the question you asked, is around technology, and there are newer technologies. But even before you get to technology, there are simple steps that could be taken that maybe many patients haven't considered, like how, for example, they receive their tablets, the routine of how they take them, the way they're packaged from the pharmacy, basic stuff that could potentially make a difference.
A 2003 World Health Organization report regarding medication adherence declared that increasing the effectiveness of adherence interventions may have a far greater impact on the health of the population than any improvement in specific medical treatment. Could you please comment this statement?
Well, if I can comment on this, I think they are true. I mean, it's a correct statement, because if you look into, let's say, randomized controlled trials and, let's say, studies with, let's say, good patients, good doctors, and all the conditions to treat correctly, we managed to control blood pressure in almost 85% of subjects. So, I mean, the drugs we have, they work. They work pretty well. They have been demonstrated to lower cardiovascular mortality, complications, everything. I mean, we have the tool to treat them. Of course, there is still a small proportion, 10-15% of people who are perhaps resistant, but we know that very often when they are resistant, it's because they don't take the drugs, but there are also some true resistant patients. But we try to improve from 40 to 60 or to 60 to 80, but new drugs will just cost a lot, and if they are developed, because now it's very difficult to develop new drugs on top of what we have and to be cost effective. And I think I agree. I think the benefit of improving, taking what we have at disposition will be much more effective than just adding a new drug on top of the new drug. There is no miracle drug in hypertension that will treat everybody to bring blood pressure to control in 100% of people.
It comes back, Michel, to your comment that if you don't take the tablets, they don't work. So, you can invent as many tablets as you like, but if you're not putting them in your mouth, they will not lower the blood pressure. And the first thing is they won't put them in their mouths unless they've had their blood pressure measured. So there are various links along this way. First of all, you've got to measure the blood pressure. You've got to make the diagnosis properly. Right. We all agree you need treatment and get engagement on that. Then once you agree you're going to take the tablets, taking them is absolutely pivotal.
Neil Johnson, would you like to
Sorry.
add something?
Just adding to Neil's point there, in terms of the steps you've just outlined, one additional step I would add, Neil, is the whole the piece about educating the patient really to a point where they understand what blood pressure is, that they understand the implications of high blood pressure, and they understand the implications of not taking their medication. So I think that's and there are ways in which now you can assess. There are tools which you can use to assess the patient's level of activation, if you like, in terms of their willingness to engage. And perhaps these need to be introduced. But can I just make a comment? All of the points, when you stand back from them, we have very effective treatment, and so we know how to treat hypertension. And the issue then is, as we say, that so people are not taking their medicines. But when you take a helicopter view of this, the way I look at it is there are four players on the field. There's the pharma company who produced the medicine. There's the pharmacist who dispenses the medicine. There's the doctor who prescribes the medicine. And there's the patient who should take the medicine. Now, in three of those cases, there is a payer who could potentially influence the game plan. The payer is ultimately paying for the production of the medicine, for the dispensing of the medicine, for the prescribing of the medicine. So it's probably in the context of value-based healthcare that we need to look at, are there ways in which these three players can be maybe more integrated in the overall picture, and maybe, dare I say the word, incentivized or rewarded for ensuring that there's a return on investment. I know people mightn't like to monetize the issue, but at the end of the day, the human cost in terms of burden of disease and the financial cost of this is enormous.
Michel Burnier?
Yeah. No, I wanted to come back to what Nell said about the consultations and the educations. I think educating the patients, it's fine. We don't have much time to do that during a 15-minute consultation, but at least we try. But I think the people we have to educate most for the moment, to me, are the physicians. Because you said that the consultations goes wrong. I mean, we take 15 seconds for the prescriptions, maybe 3 seconds to say, even if they say it, this drug has this side effect. And if you have it, don't worry, we can change the drugs. I mean, you can spend time, you can anticipate the side effects. You can talk to the patients to make them not worry too much about a cough or edema in the legs. But in fact, if you look I don't know, in England or in Ireland, but at least in Switzerland, the time dedicated to explain to physicians how to talk to patients in chronic disease, to implement the treatment, and not talking like a pharmacologist, but not talking about practical issue in drug treatment, this is not done. Asking the good questions for adherence for any treatment, asthma, lipids, obstructive lung disease, whatever, it's always the same. And here we should really, it's not only the fault of the patients, the non-adherence, it's also our fault, I think.
Interesting. Several categories of factors, including demographic, socioeconomic, healthcare team, are associated with non-adherence. So do you think that understanding the categories of factors contributing to non-adherence is useful in promoting better adherence? Michel Burnier, would you like to start?
Yes, you see, the WHO made these nice slides on the 5 major dimensions of adherence that Nell already alluded to. I mean, the social economics, of course. If you cannot buy the drugs, I mean, you won't be adherent. Patient has beliefs, he has side effects. I mean, there are really definitely things that we could work on it. The therapy is important. The numbers of drugs, this Neil alluded to, in elderly patients. So one of the big solutions, for example, is to simplify treatment as much as possible. And simplifying treatment as different components. In hypertension, we can use single pill combinations of 2 or 3 drugs, and maybe in the future 4 or 5, I don't know. But also, for example, in elderly, stopping drugs that are not necessary and that interfere with important treatment. I mean, there are lots of paper now talking about deprescribing in elderly patients because you have a kind of pollution of drugs that are not necessary that interfere with the adherence to the necessary drugs. So there is also here all the concept that we have to do. Condition related, of course. Some people, you would believe that people who are more severely ill or have a life-threatening disease will be better adherent, which is not the case. HIV patients are not necessarily adherent, even though they can die of it. Oncology patients relapse are very often due to non-adherence to the chemotherapy, which we understand because they are very toxic. Anyway, and then the healthcare system, I think the healthcare system has much to gain, as Nell said, in terms of health benefits and the cost benefit. But to save money, as usual, you have to invest money. And you invest money to help, for example, nurses and physicians to support patients at home, for example, to develop diagnosis system, to reimburse them, to reimburse single pill combinations, which is not obvious in every country, apparently. So it's always the same, and the cost saving will come with years. Unfortunately, in politics, they would like to have the results in months, not in 5 or 10 years. But I think we have to do that.
Simplifying the way people take their medication could be part of the solution, as you said. Neil or Nell, would you like to react? And there's also a debate about at what time should patients take their medication, rather in the morning or in the evening. What's your opinion?
Well, in terms of the simplification, again, if you put yourself in the shoes of if there is such a thing as a typical patient, at the outset you have a prescription that you go to the chemist or pharmacist that you fill, and if you then arrive at the point that you have a bottle or a packet of tablets in your hand, and you have no idea why you're taking them, how they're going to interact with what else you're taking, how you're going to feel. And then you open the package and you look at the instructions and it's like a foreign language. And you go back to your doctor at the next visit and there's no mention at all of the medication. It's just, how are you feeling? It's not hard to understand that if the patient really isn't in tune with what's going on, then it's fairly straightforward to understand why you're not getting what you're expecting in terms of adherence. But I mean, there's so many simple things that could be done. I know there's a legal requirement, perhaps at the level of the packaging, to have the information that's there. But maybe there could also be some simple infographic, just something very simply that, you know, makes a link between blood pressure and medicine and how they, you know, what it's going to do in 3 or 4 points. I think an accumulation of these small steps, like the packaging, the way the drugs are dispensed, developing a routine, advice about how to develop a routine. These are all small things that collectively could make a big difference.
I think you're right. Information in the packaging about the treatments can be sometimes complicated. So it's important for doctors to talk about medication adherence with their patients. Neil Poulter, do they have enough time to do so? And maybe you can tell us about your own practice.
Well, no, they don't have enough time to go through all this stuff. The typical general practitioner's slot in UK is 8 minutes. Absolutely no chance of going through a newly diagnosed hypertension to explain that problem and then to start about it. Just cannot happen. You need an hour at least, and that's what we talked about, other people supporting the services so that the patients get to understand and have the time to get it and get on board. But if I can just come back a little bit to, you mentioned the idea of the tablets, where we said if you can get your tablets in a single pill, that would be brilliant. Now, some of these would have to be the size of a biscuit for some patients, but you wouldn't do that. But if you can combine 2 or 3 tablets in a single pill that you're going to give, that is undoubtedly, we know that helps adherence. So that's something we know is a good thing to do. And I'd also like to mention the bump that comes with each tablet is terrifying, because it tells these patients this whole list of so-called side effects, which very often aren't. There's a medico-legal requirement to say these things happen on average, I think it's 3% of the time, but they may not be due to the tablets at all. So patients are terrified by that. You've got to explain that. And one of my not very subtle comments to the patients is, there's nothing I can give you as bad as a stroke or a heart attack. And that's what lowering this blood pressure we're trying to do. These side effects, you might get a rash, your ankles might swell, you might get a cough. But on the face of things, it's better than the things that we're trying to prevent. And it's trying to get that understanding. And I also try and say, we will try and avoid any side effects, but they happen. It's not the end of the world. There's a real fear on people. Oh, you're starting me on tablets, I'm going to get side effects. Well, you might, but they're not terrible. And by and large, we can change them. So I think there's lots of things we can do. Oh, and the other thing you mentioned about the timing of the tablets. There's a bit of brouhaha about when you should take them. The idea is once a day. That's what we want. We want tablets that last the full 24 hours. And then there's an argument about whether you should take them at morning or night. The best evidence to date suggests there is no evidence to prefer one to the other. There's been some worrisome trial results suggesting that you should take them at night, but I don't think best evidence supports that finding.
Interesting. What you said about doctors not having enough time to talk about medication adherence confirm figures. What do figures say? Figures reveal that the topic of medication adherence rarely comes up during office visits. 61% of the patients said that they rarely or never talked with their doctors about how often they took their medication. So many people talk about patient education. Should there be also a doctor education as far as this topic is concerned?
Absolutely. It must be, it's part of the education of the doctors. Michelle mentioned earlier, we've got to educate the doctors. It's part of the things they need to know. And of course, it won't come up if the blood pressure is well controlled, by and large. If the patient's doing well, how do you feel? Find any side effects? No. Your blood pressure's brilliant. You're not going to go on and say, how often have you taken the tablets? But if the control isn't good, that will raise your suspicions. And that's when you need to go into it in a subtle way, without being aggressive and blaming the patient. That's the key issue, I think.
Michel Burnier, what's your opinion?
No, I totally agree. I think I give my opinion on the education of doctors before. I think the way we ask, the way we ask is as important as asking. I mean, already talking about it is probably the best way to improve. We have to start talking about it. But now, how we talk, then we have to learn. And we have also to listen to what they say, because a lot of people say, well, no, blah, 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 I have this and this and this. And they say, okay, keep on doing and keep on taking. I mean, we have to listen to what the people say and to find solutions for them, because sometimes there are simple solutions. For example, people, stress when they go to work, they miss their drugs at home. But then I tell them, have another box of drugs at work. So if you realize when you arrive at work that you haven't taken them, you can still take them, and all of these kind of things. Just to make a brief comment on the evening and morning, I agree with Neil. There is little evidence. I mean, there is one group that really published on the evening dose, but all the others, I mean, there is little evidence. And the drugs are usually better taken in the morning than the evening. We looked at the adherence and the difference between morning and evening. And in the evening, you have 20% less adherence to the drugs than in the morning. Just because the definition of the evening is relatively bright in the population. It can start from 7 o'clock in the evening in winter to 3 o'clock in the morning when people get back from dancing, So when is the evening? Well, the morning is more or less standardized between, 5 and 9. Things like that. So,
very often, patients become non-adherent early in their treatment plan because the experience doesn't match with their expectations. So, Neil Jensen, how to work on patient education in order to help them to be more motivated?
Yeah, I don't think it's just that the medication doesn't match their expectations, because I think it's more to do with what we've discussed already, their understanding. And that's down to, again, the issues we've discussed around the time that's available to a doctor. But also, I keep coming back to this piece of the patient themselves and their own, I suppose, cognitive capacity, their own place where they're at in terms of their understanding of their condition. So I think the education piece is a big piece, and I think part of the education dimension, I think, needs to have an integrated approach as opposed to just, there's a potential here that this could just turn out to be sort of bashing the doctor because the doctor isn't doing his or her job. There are, as I said earlier, 4 stakeholders in this equation, and the question of accountability has to come into it. The patient has to be accountable for their own health. The doctor has to be accountable, ideally, for an improved outcome. I think the pharmacist has a role to play in this in terms of accountability. They are dispensing medicines, and currently there is no place in that process for the pharmacist to actually inquire, are you taking the medicines? What are you doing with them? And then I think the pharma company has a role to play in supporting all of the stakeholders in the education journey.
Hypertension is in... sorry. Go ahead.
Again, I think it's an interesting question. Definitely, the risk of non-adherence is much higher in newly diagnosed than on older hypertensive, because older hypertensive, of course, they have accepted that situation and they have integrated a little bit better. But one thing which is really typical of hypertension, especially those with mild to moderate hypertension without symptoms, I would say, not severe hypertension with headache, but the mild to moderate hypertension. What people have to understand is that usually they feel good when they are hypertensive, and then they will feel tired when they take the antihypertensive therapy and blood pressure lower. So what happens almost inevitably in the first 3 or 6 months of patients, that patients will feel tired because they have a lower blood pressure. So they have more difficult to go on, and they say, I was feeling better when I had high blood pressure. So you have to, this is again typically a situation that you have to anticipate. When I prescribe to my patients, newly diagnosed patients, I say, okay, this pressure down, be tired. You're going to be tired for the next 3 months, but don't worry, keep on going with your drugs because it will disappear. And then in 6 months to 1 year, the reverse will happen. You will feel good on the low blood pressure and bad on the high blood pressure. And this is a very important thing. The changes in the brain which occur with the high blood pressure makes the blood pressure better tolerate. You have to reverse this phenomenon so that people feel better on the low blood pressure and feel actually symptomatic as soon as their blood pressure goes up.
And this is a very good point, because hypertension, as you said, is in many cases an asymptomatic disease. So since patients do not suffer from the disease, all restrictions and constraints can be viewed by them as the pain points. So the question is, how shall we explain to them that they have to comply with a strict standard of care, not necessarily to treat current symptoms, but to prevent, as you said, future complications?
Yeah, but we have to talk about it. And you have to know what is hypertension. Actually,
Neil Poulter?
You know the disease.
Well, I was just going to say that we take for granted antenatal care. Women go routinely to hospital throughout their pregnancy, not because they've got a problem, but to stop them having a problem or to pick up any problems. And it's a preventive strategy. And that's what high blood pressure treatment is all about. It's not because you have an illness or a symptom now, it's because to stop you having something going wrong in the future. And in the same way we accept it in antenatal care, everybody accepts that, we've got to learn to accept it for risk factor management like blood pressure too. So it's back to this education thing again. It's a key piece in the whole story, educating the doctors, educating the patient, and getting buy-in from everybody.
And something else, each patient, I guess, has its own perception. So isn't it a major challenge? Indeed, they may not need the same kind of support and resources. Neil Jensen, what's your opinion?
Well, I think as Neil has said earlier, there's no one-size-fits-all here. You have patients who unintentionally are non-adherent. Some studies would suggest that could be as high as 40%. They just forget, or too lazy, or their circumstances don't allow, they're traveling or whatever. You have others for whom there's a cost barrier. You have others who have, I suppose, a belief system that is based on false evidence or even fake news. So you have people very sensitive, for example, to the media. In the recent COVID crisis, we're all aware of the varying opinions about hypertensive medication and greater risk of infection. All of these variables are really impactful at patient level. So there is no one size fits all in terms of the solution to this. But fundamentally, what you're talking about here is introducing a new behavior. This is in the instance of somebody being prescribed for the first time. And in introducing that new behavior, you have to create a habit, you have to develop an attitude, a belief system that will encourage them to continue taking the medicine. And the fundamental underlying aspect of that is, do they understand what the condition is? Do they understand the importance of their medication? And if they don't, all of the other variables just enhance the non-adherence.
Neil Poulter, would you like to comment on that?
No, I thoroughly support absolutely that. It is about assessing adherence should be done routinely if you've got no control, and then tailoring your intervention to the cause of the lack of adherence.
So I think we all discussed the fact that patients may not be well informed, and in order to improve their knowledge about adherence to treatment, a new communication campaign has been launched. Professor Poulter, can you please explain us what it is all about?
Well, really, yeah. Let me just bring you back to this slide I showed earlier. That bottom row there, less than half people with hypertension were aware of it around the world. Moving to the right along there, most of those get treated, 40.6% to 46.5% of that lot. But then look at control. Only a third of those who are getting treated are being controlled. So there's a huge drop off there, and there's a huge problem with the awareness. So there are two key problems. And so what happened was I proposed that we should have a thing called May Measurement Month, which was a global screening campaign to try and just raise awareness of the importance of getting your blood pressure measured. And linked in with that, Servier set up this Because I Say So campaign to raise awareness. And you can see us shaking hands there. It was a marvelous setup, and I'll show you the idea in a minute. But basically it was Because I Say So. It was the inverse of the usual thing. Parents telling children to do as they're told because I say so. It's the other way around. And what they did in 2018 and 2019, it was young adults talking to their parents saying, go and get your blood pressure measured. Why? Because I say so. And you see there were 50 million views in that campaign in 2018. Absolutely fantastic. And that was run in the run-up to May to sort of try and drive people towards the May Measurement Month campaign. The campaign was even better in 2019, and it had over 150 million views, and this was kids either talking to their parents or grandparents, really cute settings, just showing these kids saying, come on, Grandpa, go and get it measured. And so it was a brilliant campaign, I thought, and then so that really was the awareness side of things. And on the next slide, you'll see that we then move on to the problem of control. And just to summarize some of the things that we've said together as a group, here you've got it isn't well controlled, and one of the reasons is the patients are not taking the tablets. Why do they not take the tablets? Well, they get side effects, and they start off, as you see that second bullet, it's usually an asymptomatic disease. So you're saying to somebody who feels perfectly well, I want you to take this tablet, maybe 2 or 3 tablets, for the rest of your life. Now, if we all were given an antibiotic course, you've got to take 4 tablets a day for 10 days. What happens when you've taken them for a week and your sore throat has gone or your skin rash has gone? What do? You throw them in the bin. You do not finish the course. But we're expecting people here who feel perfectly well to take these tablets for the rest of their life. And so they may feel worse, as Michelle said, than they did already. And then the other issue is they say, well, okay, if I take the tablets, will this stop me having a heart attack and a stroke? Well, I can't guarantee that. It reduces your risk, but it won't necessarily get rid of the risk. Oh, okay. Well, if I don't take the tablets, will I definitely have a heart attack and a stroke? Well, no, you probably won't. So it's all sounding a bit weak in terms of education. And it's that background that you began, Michelle, saying the odds are against us trying to persuade people to do this. It sounds pretty bad argument, but it isn't. Then we've got the others, the costs that we've mentioned. Some people can't afford it. That's got to be got round. People are older. They forget. They genuinely forget. But they don't have the understanding very often. This is where the doctors come in. They've got to understand that it is worth it. And we explain that. And that's where the physician inertia is to blame, because we don't bother explaining to the patients. And I think we must do. So to address that lot, Servier changed their Because I Say So campaign. Up until 2019, as I said, it was all about awareness, getting the diagnosis, driving people to get their blood pressure measured. But then from September this year, this changed from an awareness campaign to an adherence campaign. And the last slide just shows these three delightful little scenarios here of cheeky grandchildren speaking to their relatives, telling them, and the middle one says exactly what Michelle said earlier, if you don't take it out of the bottle, Grandpa, it's not going to work. And these are the sort of little messages driving adherence, and hopefully this will be equally successful as the awareness campaign. I'm absolutely delighted this is happening, and this will link in with our May Measurement Month campaign, which hopefully will restart next year. In 2020, obviously, it couldn't. So these are fantastic collaborations to help the general population, everyone involved with blood pressure, to try and improve the outcomes, and that is getting patients with high blood pressure, getting their blood pressure controlled.
Michel Burnier or Neil Johnson, would you like to comment on this campaign?
I love the idea of involving the younger people also in the relationship and the support for grandparents or parents to do that. And in a way, it's a great idea because involving the partner is not always a good idea. Sometimes, if the wife takes care of the husband or vice versa, it generates some conflicts with age because some people want to be independent and want to handle themselves. So it's not always. But here, involving another generation, it's not the same interaction, and I think it's a fantastic idea. I really loved it. Congratulations, I think. Yeah.
Neil Johnson?
Yeah, I think everybody is aware of the May Measurement campaign. I think it's been a fantastic success. It's about awareness, which is obviously the first step in the process. And obviously, I wish the adherence campaign every success. I think this is going to be the challenging piece of the jigsaw for all of the reasons we've discussed. I think at the end of the day, it's about ownership. The patient needs to take ownership at that level, first of all. And then whatever we can do, whether it's the encouragement from a grandchild or whatever, whether it's using technology, whether it's some sort of reward and punishment mechanism, whatever it takes, I think we need to be open to it. And I think it's a great initiative, and I wish it every success.
We have reached almost the end of this webinar, but before we finish, I would like you please to tell us a few words about what we should keep in mind, maybe what will be your takeaways. Shall we start with you, Michel Burnier?
Well, to me, the takeaway message will summarize in 2 or 3 sentences that Neil alluded to in the beginning. I mean, hypertension is inducing a lot of cardiovascular complications. We know we can treat them. We know we can prevent all these complications. I think this is extremely important with the drug we have. But the issue is that drugs work only if they are taken. And we should, I can only say to patients, please take your drugs, and to physicians, please talk about drug therapy with your patients and try to support them and find good solutions for them. It's very important.
Neil Johnson, what will be your conclusion?
Well, I think there's a couple of numbers here that I think we should not forget from this conversation. 9.4 million people dying, a third or greater of people not reaching target on prescribed medication. So there is a huge cost, a huge economic cost, and there's a huge health burden to society. We have the answer. The answer is take your medicine, and that's been proven. What I would love to see is a greater integration between the stakeholders, and that is the patient, the doctor, the pharmacist, and the pharma company. Is there some mechanism by which all 4 could sit down together and work out some model of reward, reinforcement that could maybe just move that dial forward even a few percent?
Thank you. And Neil Poulter?
Well, another way of saying much the same thing as Michel and Niall. The 9.4 million was the figure in 2015. it rose to 10.4 million by 2017. Massive increase. And that works out as 28,000 deaths per day due to raised blood pressure. Okay, that's like 70 jumbo jets crashing every single day and killing everybody on board due to raised blood pressure. We have got to do better than that. And we know that the things driving it are awareness or lack of awareness. And once you are aware, and once you are treated, we're not getting control. And a key driver for not getting control is lack of adherence, a big player. So I would just reassess the criticalness of reaffirming the awareness, measure it, screen it, that's got to be done better, and then make the assessment of adherence routine. And then when you find that there are problems of adherence, help the patient, work with them to work through a solution for their lack of adherence with empathy. And I'm delighted to see with the two campaigns that one of the stakeholders, in this case Servier, have joined in with the International Society of Hypertension on May Measurement Month to drive, first of all, awareness and now adherence. It's fantastic. I'm delighted.
Thank you very much to the three of you. Thank you to all of you who have been watching us, and thank you to Servier teams who made it possible. Have a very good day. Bye-bye.